Hi, everyone. So now that we have our estimated calorie and protein needs by Stacy, how are we actually going to ensure adequate nutrition delivery for this patient? So just to summarize again, ICU day 2, significant volume overload, plus 20 kilos. In terms of hemodynamics, still somewhat tenuous, overall improving, meeting perfusion targets, vasopressors coming down, has ischemic hepatitis with low urine output, less than 500 mLs, with acute on chronic kidney disease. In terms of nutrition risk, this patient's already been hospitalized 2 weeks prior to transferring to the center for this high-risk surgical procedure, and per electronic health records review and also discussion with the patient's family, he's had suboptimal nutrition at the outside hospital. So already this 2 weeks inadequate nutrition with a large nutrient deficit going into surgery, also has significant weight loss, with a diagnosis of severe malnutrition with significant weight loss. And so unfortunately, this is a common scenario when patients are being transferred for a higher level of care. They may have already been in the hospital for weeks, experiencing inadequate nutrition with large accumulated deficits. So knowing this information, this is an audience poll question. What would you guys, with the show of hands, please recommend for this patient? So are we going to do 1, exclusive EN, 2, exclusive PN, 3, a combination of low volume, okay. That was for exclusive PN. And then 3, a combination of low volume EN and supplemental PN. Great. And 4, no nutrition support withholding both EN and PN. Okay, great. So for this particular patient, I'm going to favor option number 3, a combination of low volume EN with supplemental PN, and that parenteral nutrition really meeting majority of the estimated calorie and protein needs. And there's a few reasons why I want to select this plan. The first being, I don't want this patient to develop worsening malnutrition or worsening nutritional depletion. Given excess calorie deficits over 6,000, over 10,000 in your surgical populations is associated with worse outcomes. So impaired or delayed surgical wound healing, with the worst case scenario being dehiscence or evisceration, more days on the vent, more infections, more antibiotics, longer ICU, longer hospital length of stay, overall increased mortality. Enteral feeding protocols, even with our most robust enteral feeding protocols or peri-procedure fasting protocols to reduce unnecessary EN holds, these patients can still often experience calorie deficits up to 9,000 per week. And to date, our medical ICU patients or our MICU patients have been more of the focus of research on calorie and protein deficits. However, our surgical populations are significantly less likely to achieve their calorie targets compared to their medical counterparts when they're relying on exclusive EN alone. And why is this the case? So although EN interruptions are obviously common in all ICU populations, of course, even in the MICU, in our surgical populations, we tend to see more invasive procedures and diagnostic testing being required. Some of these patients have to go back to the OR daily. These patients also tend to experience more GI-related intolerance. So starting out on days 1 through 3, it's not uncommon for our patients to receive no nutrition during this phase. But if they are hemodynamically stable, maybe we're going to start out at 10 or 20 mLs an hour with the plan to advance. There's a good chance coming up on days 4 through 7, the feeds might just be held for some sort of procedure or test. We also have to consider different providers are often rotating every day, so they're not always able to appreciate the big picture in terms of how these accumulated deficits are building up. It's not uncommon to hear in team rounds, we're going to hold off on PN, we're hopeful to restart feeds after the procedure today. And what ends up happening? Either the case gets bumped, or we do restart feeds, and maybe they develop some sort of GI intolerance symptoms where we have to pause the feeds again, and there's another 2 or 3 days of this delayed adequate nutrition. Observational studies reveal EN is held for an average 8 hours per day in the ICU setting. Some patients are receiving the equivalent of trophic feeds just running at 20 mLs an hour for 7 days, so easily accumulate this 10,000 calorie deficit. It's not uncommon for it to take up to 7 days before full coverage of energy needs is achieved with exclusive EN. And so during all these enteral interruptions, how can we bridge the patient in that first week until we're able to achieve those target enteral goal rates? And so I noted my plan was to start supplemental PN, but I first want to differentiate between the two strategies and how supplemental PN is applied in the first week. And I want to do this because I realized when I was having more discussions with dietitians and providers about supplemental PN, the version that I utilize is actually way less familiar to clinicians. And so with supplemental PN plus EN, so on day 1 through 2, EN is initiated. By day 4, if you're unable to meet at least 60% of nutrient targets, supplemental PN is started to achieve 100% of calorie and protein needs. So EN remains the primary method, and supplemental PN just comes in to fill in the gaps after EN falls short. With EN, low volume EN plus PN. So this is an early combination of you're starting PN early with low volume EN. For anticipated EN interruptions. And so you're basically, as early as ICU day 0 to 1, based on the degree of surgical or post-op complications, it's going to be very challenging to feed that patient enterally or meet their nutrient targets in that first week. So you're pulling the trigger on that early PN. You also maybe want a slower, more gradual titration for EN, such as 10 mLs, Q8 or Q12 hours, because maybe they're hemodynamically still unstable or they're at high risk for any GI intolerance. So PN is running in the background with a slower EN titration until you're able to meet 60 to 80% of nutrient targets by EN alone. And if you think about it, this is the best of both worlds, right? That low volume EN providing all the immune and gut integrity benefits of enteral nutrition. You're not aiming for full EN goal rates, which could potentially help to reduce the risk of any GI intolerance in the setting of impaired or altered intestinal perfusion. We're able to support reduced mortality with this early low volume EN, and that supplemental PN really meeting majority of your estimated calorie and protein needs. So you're able to obtain immediate achievement of your nutrient targets with that PN. And this can actually be really important because if this patient was on CRRT, protein needs 2 to 2.5 grams per kilogram. For some patients, that's as high as 150 to 200 grams of protein every day. There's no way I'm going to be able to meet those protein targets with EN alone. In that first week. We're really just utilizing this strategy as a temporary bridge in the acute phase until the patient has stabilized, where ideally we can transition them to full feeds. That usually takes place around the second ICU week. So what do our established guidelines have to say about supplemental PN in the first week? So ASPEN 2023 really noting it should be on a case-by-case basis. ASPEN 2022 also indicating this case-by-case basis using patient-specific clinical judgment. They also note it's okay to wait 7 days for your average non-malnourished ICU patient. And that is exactly one of the main limitations of this guideline. Majority of the patient population represented in the 6 RCTs supporting this guideline reflect the average ICU patient with a shorter ICU length of stay, lower illness severity, and overall lower nutrition risk without malnutrition. And out of the 6 RCTs this guideline is based off of, the one with the largest patient representation, which is about 4,600 patients, came from the APANIC trial from 2011, which Dante just briefly spoke about. So a lot of the commentary around this RCT is, why are they even providing supplemental PN to these low-risk populations anyway? In most ICUs around the world, they wouldn't even be receiving artificial nutrition. This is also the only RCT that reported worse outcomes with supplemental PN, but it was, again, applied to the wrong population with some major limitations to the methods that were utilized, such as providing massive IV dextrose loads with no lipids and protein in that very early stage for the intervention group. They were 60% routine cardiac surgery patients, very short ICU length of stay, median 3 to 4 days, and also Nutrix score of 3 to 4 days, 3 to 4, so very low nutrition risk. This is also the same RCT that was the main supporting evidence for the 2016 ASPEN guidelines, indicating to wait 7 to 10 days before starting supplemental PN. And given there was worse outcomes noted in the APANIC trial, the word for these guidelines, the word detrimental was used. From my point of view, that's basically suggesting you are going to cause some serious harm if 1 drop of PN is provided when EN is infusing at the same time. And I don't know about you guys, but this is when I started to see kind of a one-size-fits-all approach with PN, where there was just like a lot of fear of harm, and it was just kind of avoided at all costs during the first week. But the problem is we can't apply the APANIC trial to high-risk patients or with a high illness severity or significant post-op complications with underlying malnutrition or just being at high risk for developing malnutrition. But that seemed to be exactly what was happening. So what was the aftermath of this guideline? A survey of dietitians and physicians in 2022 revealed about 60% of respondents would only consider supplemental PN after ICU week 1, 17% would actually wait over 2 weeks, and another 17% wouldn't start it at all for any reason in a patient also receiving EN. This reflects the real day-to-day practice of these patients. And what we're seeing is providers are delaying PN well beyond the 7 to 10 day period in patients also receiving inadequate EN. And when we evaluate meta-analyses that specifically remove the APANIC trial because of its lower risk population and its flawed methods, we see that that combined EN plus PN approach versus EN alone not only ensures ability to reach calorie and protein targets with no negative effects on clinical outcomes, but is also associated with reduced infection and also ICU mortality. But so many of these RCTs are focusing on these hard outcomes such as mortality. We now know there's some major limitations in utilizing mortality when we're evaluating the effectiveness of nutrition intervention trials. In recent years, we've seen a big shift, and the focus being on nutrition delivery and impact on muscle mass, muscle quality, physical function, and quality of life measures. And so Dr. Eileen Hill and colleagues, they took their meta-analysis on supplemental PN versus EN a step further. They did look at those hard outcomes, such as mortality, but they also focused on functional outcomes. So the aspects of nutrition that can really make a difference. And their analysis revealed that 2 out of the 4 studies that actually focused on functional outcomes for the patients who received supplemental PN, they had improved trends towards improved hand grip strength, 6-minute walking test, also more functional independence, and improved quality of life. So even though we see some real benefits of supplemental PN, it's still very much underutilized. And that might be due to the lack of specifics in the phrasing of case by case as recommended by these guidelines. So what are some important variables for us to consider in this case-by-case approach as we're thinking about it for our own ICU population? So the first being that pre-existing nutrition status. So this is why, as clinical dietitians, some of your ICU assessments easily take you an hour or longer. In addition to evaluating all the pharmacological and medical aspects of the patient, you're taking the time to gather that very important malnutrition data. You're looking at the dietitian notes from the outside hospital. What was their nutrition status prior to coming to the hospital? This is going to be very important in our decision-making for supplemental PN. We also want to consider the population. Does this patient have a high illness severity with an anticipated prolonged ICU length to stay over 7 days? We all know how our patients can be admitted nourished without malnutrition and quickly become malnourished based on the degree of post-op complications or illness severity. Are they a complicated surgical population with inherently more post-op organ dysfunction after surgery, or are they ECMO population, especially our VA ECMO populations, which tend to be significantly underfed in that first week in the stabilization period? We also want to consider the phase of critical illness. We want to make sure we're providing PN to the right patient at the right time. And so in that early acute phase, day 1 through 2, as Dante and Stacey have talked about, the primary focus of the body is to survive in large endogenous glucose production, high level of stress hormones, organ dysfunction, and inflammation. Patients may fail to properly utilize nutrients effectively in this phase for anabolic purposes. So if there's no malnutrition, obviously we can hold off in those first 1 to 2 days. Any excess macronutrients are not going to be utilized effectively. In our days 3 for 4, majority of your RCTs actually for supplemental PN actually focused on days 3 to 4, what has been suggested as the acute late phase when the endogenous glucose production has been exhausted. The body may be more metabolically able to process nutrients or have a higher level of metabolic tolerance at this time. And if we are starting supplemental PN in an already malnourished patient, which I think we should be doing, we're already very conservative with our calorie and protein load, especially our dextrose load for strict refeeding syndrome precautions. Other considerations is the setting in which PN will be applied. When we see supplemental PN provided on a regular basis, those institutions are ensuring rigorous catheter care and line management. They implement advanced infection control procedures with robust CLABSI surveillance programs, including daily rounding on catheter care adherence. We also need expertise in PN management, so that daily close metabolic monitoring, so that daily assessment of volume status, carbohydrate, protein, and lipid tolerance. We also want to consider the dose. When we see supplemental PN applied correctly with a high level precision, we see indirect calorimetry utilized, often starting on day 4. And if we're utilizing predictive equations versus IC, given there's a lot of potential error with these equations, it's been suggested not to exceed over 70% of energy targets in that first week, and that's per ASPEN 2023. So back to this patient. Okay, so here's my case-by-case analysis for supplemental PN. Already malnourished, large nutrient deficit. I anticipate ongoing EN eruptions, inadequate EN delivery in that first week based on the degree of complications. They're still somewhat hemodynamically tenuous with the recent bowel injuries, so I want to aim for that low volume EN with a gradual titration. What are some important considerations? Keeping in mind, this is the height of critical illness. Patient has significant volume overload with shock liver or acute ischemic hepatitis. And so we're going to be starting EN at 10 mLs an hour, providing a very minimal amount of calories and protein. That actually just might end up being held. In terms of volume status, so it's really important our PN is customized to meet the medical priorities of our patient. So if they already have significant volume overload, there is no reason to provide an additional 1.5 to 2 liters of PN. So we need to be able to assess volume status and the need for that max concentrated PN. So we're going to be looking at urine output trends, peripheral edema, total net INO balance, longitudinal central venous pressure or CVP trends if that's being monitored, and considering your CVP trends over 12, 15, getting up to 18 or 20 are going to represent a volume overload and over-resuscitation. This patient is massively volume overload. Pharmacy is probably already concentrating all the drips as much as possible. The team is trying to pull off as much volume as possible, so I want to aim for that concentrated PN to support diuresis and net negative fluid balance goals. My goal is to get less than a liter and really to provide the minimum volume required to maintain sufficient nutrients in the PN solution. So I'm going to ask the team if I can swap out the low volume D5 half NS running at 25 mLs an hour for a very low volume PN bag at 600 mLs. In terms of dextrose, this patient already, high risk of refeeding syndrome, so I'm going to aim for around 100 grams of carbs or less for day 1 and advance pending electrolyte status. Also going to add some thiamine. As we are advancing carbohydrates and assessing carbohydrate tolerance, it's not uncommon for these patients to have some sort of continuous IV insulin infusion to obtain precise glycemic targets, getting that blood sugar less than 180. If we don't have insulin drip and the blood sugars are consistently over 200, this not only leads to infection risk, but can also lead to poor surgical wound healing, impaired calorie absorption, and also dehydration. So hopefully clinicians are well versed on how to dose insulin for the parenteral nutrition, also considering adequate sub-Q, both the type and amount of sub-Q insulin outside of the bag. We also want to keep in mind all the other factors that can contribute to insulin resistance in the ICU setting, especially any pre-existing diabetes, which is often very much overlooked. We cannot be shocked if a patient requires over 60 to 70 units of total insulin in the ICU setting on PN and assume this reflects carbohydrate intolerance when their home insulin prescription is a total 80 units of combined basal bolus insulin. We also want to consider triglyceride monitoring, not just for lipid tolerance, but also for carbohydrate tolerance. Any excess dextrose burden is just going to drive triglyceride production. It's actually been suggested in that first week to consider just the baseline carb needs, around 150 to 200 grams of carbs, while keeping your GIR less than 2. In terms of protein, if you guys have access to 20% of amino acid, this is actually really helpful to meet protein targets in the smallest volume possible, which is really important if your ICU population is prone to volume overload. With a 15% amino acid, and if you're maxing out the bag, you can actually fit in a solid 60 grams of protein. For this patient, that's around 0.08 grams per kilogram. They're also receiving some protein from the EN. As we are monitoring protein tolerance, We're going to be utilizing BUN and creatinine trends, also urine output trends. It's been suggested that an adjustment to protein dosing should be considered if your urea levels increase twofold from baseline levels with a stable creatinine. But I think it's important we need to consider all the non-nutrition related factors that can contribute to AKI in the ICU setting, such as diuretic therapy, especially loop diuretics at high dosing. It's not uncommon for your post-op patient to receive minimal to no nutrition for the first 5 to 7 days on very high diuretic dosing, such as bumetanide, 4 milligrams, BID, TID, and their BUN is just continuing to climb, 80s, 90s, 100, with minimal nutrition. So if you're already aiming for a lower protein dosing and they're barely receiving that, and the BUN is just continuing to climb on these high diuretic dosing, we have to consider all the other factors contributing to pharmacological and medical factors contributing to AKI as well. In terms of lipids, it can be really challenging to provide any PN lipids in the setting of high dose propofol. This patient's already receiving about 400 calories from propofol, or about 30% of calories coming from lipids, which is our goal for parenteral nutrition, so I'm going to hold off on lipids. What about providing PN in the setting of acute ischemic hepatitis or shock liver? And so providers may want to avoid PN altogether in the setting of acute ischemic hepatitis or shock liver. The concern or assumption being that PN may worsen liver function. However, it's well known that any PN-associated liver disease or liver dysfunction is really more of a concern in patients receiving long-term PN. So that's months to years of therapy. That's not really the case for our critically ill patients, which tend to receive PN for maybe a couple weeks, rarely a few months. So if this type of discussion does come up in rounds or any setting, I do find it important to differentiate between the differences in metabolic complications between short versus long-term PN. For this patient, way more concerned about the short-term complications: fluid balance challenges, electrolyte disturbances, hyperglycemia, elevated triglycerides. Any type of PN-related liver dysfunction or hepatic burden usually takes a minimum of 2 weeks of therapy and is the most prevalent in the setting of overfeeding with really high dextrose loads. So another reason why we need to be careful with our dextrose. So as we are, for this patient, as we are advancing and ramping up the tube feeding and PN is running in the background, we're going to wean PN once we're able to reach 60 to 80% of EN goal rate with demonstrated adequate GI intolerance, no further anticipated EN interruptions. So there's no point of pulling the PN off if they're just going to hold the feeds the next day for another procedure. So by day 7 to 10, for this patient, day 7 to 8, we're able to fully wean off PN and get to our tube feeding goal rate. So this is one perspective on how to apply supplemental PN. How do other centers apply supplemental PN? This is a group of renowned international nutrition expert physicians. They met to discuss the values and barriers of supplemental PN. So these are doctors who utilize supplemental PN on a regular basis in their ICUs. And these are examples on how they consistently use it. And some of the examples that stood out to me are failure to reach energy targets by ICU day 4, any pre-existing malnutrition with the goal to prevent further deterioration, prolonged significant vasopressor requirements after a complicated surgery. And so the authors, they agreed that overall inadequate MNT largely depended on the treating physician's beliefs. And this really spoke to me because we all experience how nutritional support practices vary across ICUs within the same hospital and even amongst healthcare providers within the same ICU. So what that means to me is 2 patients can come out of the OR with a very similar degree of post-op complications and barriers to adequate feeds. One patient will have PN started early, and the other patient might have inadequate feeds for an average 7 days. So how can we better align PN practices when EN falls short? So the authors agreed to develop precise protocols, translating guidelines into clinical practice. And how are guidelines or protocols often created? They're usually a result of quality improvement initiatives. So if you see the same thing happening over and over again, excess tube feed interruptions, minimal nutrition support for those first 7 to 14 days, difficulty meeting nutrition needs with EN alone. For this patient, 30% needs in 15 days. You might want to start tracking this data and evaluate what are the barriers to adequate EN in your population. Are these avoidable EN holds or unavoidable holds? Would several of your patients benefit from that early supplemental PN or just exclusive PN, but PN is often avoided? Consider an internal audit looking at calorie and protein deficits, ideally targeting those first 2 weeks of ICU admission when it's the most challenging phase to feed these patients. What percentage of nutrition needs are actually met? What are the rates of malnutrition? And tie these nutrient deficits into impact on costs associated with malnutrition, ICU, hospital length of stay, any wound healing trends. Do these patients have non-healing stage 3, stage 4 wounds or non-healing surgical wounds, and overall mortality trends as well? And take this data and go talk to your quality leaders and your department leaders. And if you're able to get all the pertinent key stakeholders in the same room, this is a great opportunity to assess the barriers to adding PN when EN falls short. So what are your physician or your surgeon concerns for providing PN in those early periods? The goal is to expose the lack of agreement with the aim to build consensus. So this is a great time to review some of those PN myths or those feared consequences and discuss how, PN is no longer just this last resort in the setting of severe GI intolerance states, but we actually use it as a pure source of calories and protein, even with a fully functioning gut now. If they're concerned, talk about how we can customize PN to provide way less volume now, especially if your providers are concerned for volume overload, and also how providers are usually used to just exclusive EN or exclusive PN, one or the other, not both. This is a great time to increase education on the benefits of that low volume EN, gradual titration with supplemental PN, and to say yes, we are still using the gut. You are still getting the benefits of that enteral nutrition. And despite high quality RCTs and our ASPEN guidelines indicating no difference in infection with a short course of EN versus PN in that first week, this is still one of the main hesitations to start PN, is that concern for infection or central line associated bloodstream infection. So when I hear this, the first thing that comes through my head is ICU patients can have a very heavy central access burden, often resembling this. And our surgical populations can easily have up to 9 ports with several lines and lumens. This is a great time to actually review and remind the team what is the actual pathogenesis of eclampsia, and how the most frequent cause is contamination of the catheter hub by contact with the hands, contaminated fluids, or devices. And this can happen with any CVC line or port, regardless of the infused. The risk is not exclusive to the catheter or lumen solely utilized for exclusive PN. A good time to review what are the actual factors to reduce, and evidence-based factors to reduce eclampsia, and how a short course of PN for 1 week is no longer considered that risk. And if you need to take it a step further, you can consider an internal nutrition audit on your eclampsia patients. Can you tell I love audits? So go back and see, what eclampsia patients, what was the main type of nutrition utilized? What was nutrition adequacy? You might find majority of your eclampsia patients had inadequate exclusive EN with large nutrient deficits and diagnosis of malnutrition. Important time to review what are the differences between what has changed from the early 90s to 2000s, from overfeeding, poor glycemic control, suboptimal catheter care, as Dante talked about, and to our modern ICU era. High priority to achieve glycemic targets, drastically improve catheter care protocols and standards, and our customized PN with that close evaluation of metabolic tolerance. Propose an evidence-based solution and track your outcomes before and after the protocol. It really helps to have a surgeon or physician champion like Dante to work with to strengthen your overall outreach and your overall influence. And so when we did this at our institution, we did take into account that patient population, and based on our internal audits, patients coming out of the OR with these complications had significant underfeeding with very high rates of malnutrition with EN alone. So we created a protocol incorporating an earlier start of PN, both exclusive and supplemental PN. We did take into account the pre-ICU nutrition status and also the phase of critical illness. We put some logistics for PN, so considering the dextrose load and also the calorie load and also volume considerations, which was a big concern of our intensivists, especially in the setting of severe ventricular dysfunction or failure. We actually added the whole EN plus PN phrase on our visual aid training talk card to really start to normalize this concept, to say, yes, you can provide PN as a source of nutrition, even with a functioning gut when EN falls short. And with this protocol, when we had adequate adherence over 3 years, we were able to improve calorie deficits by about 10,000 calories in those first 14 days. We had significantly increased our EN plus PN utilization. We also had way earlier PN start dates for about 10 days earlier, and we had no difference in CLABSI with that increased early PN utilization. This was actually associated with the decreased ICU length of stay from a median 34 days down to 25 days. And so it's really important that we're showing our quality leaders the use of supplemental PN might not only improve your patient care related outcomes, but also your ICU related costs. So if I'm able to decrease ICU length of stay by a median 9 days with this nutrition practice change, this is huge cost savings of about $56,000 per patient. So my main take home point is nutrition QI initiatives to get more PN utilization started at your institution can take a lot of work to develop, to get going, implement, and sustain, but have been shown not only to enhance your team collaboration and your team trust, but can improve patient care outcomes, especially for challenging surgical populations that are constantly fed with EN alone. And so back to this case, as this patient is now coming up on post-op day 7 to 8. Okay, fully weaned off PN, now on full EN. So AKI has worsened, and nephrology is consulted, and they decide it's finally time to start CRT for fluid overload and metabolic acidemia. So questions to our panel. First thing is, how will CRT initiation change your nutrition therapy? Actually, I can go first. Yeah. Okay, cool. I'll go first. So I just want to, so the main thing I'm thinking about, this is a good time to assess for any micronutrient deficiencies going into CRT, which is known to cause further deficiencies in your B vitamins, vitamin C, copper, zinc, selenium. So in addition to checking copper, zinc, and selenium, I'm going to add a multivitamin with minerals that has at least 2 milligrams of copper, 70 micrograms of selenium, 15 milligrams of zinc. Also add an additional vitamin B6, folic acid, and vitamin C. So we recently changed our protocol at our institution, and we no longer provide Nephrovite, which is designed for our maintenance dialysis patients. So we use a multivitamin with minerals. So what would you do?
I would probably increase the protein by about 15% at this point, especially in the parenteral component. So I agree, I would probably be giving combined modality nutrition. But what we learned from the Nuturia is, like, you don't want to go full hog, you don't want to go full on with the enteral nutrition. So I've been told, and I believe this, that about 15% of the parenteral protein is lost across the diastole membrane and doesn't come back. And so my practice is once they go on to renal replacement therapy, then I'll just times 1.15 in whatever I'm prescribing.
Yeah, definitely. When the CRT is started, and also hopefully between the first assessment of the energy and protein needs and this point, they've been continuously reassessed as well, and you're not still functioning from that first indirect calorimetry and that first protein target, because by this point, even before the CRT started, those would probably, particularly that initial protein target, be too low.
Great.
And then I can field the second question as well. So with CRT, you can definitely still do indirect calorimetry. I wouldn't do it the moment the patient is going on indirect calorimetry. Definitely wait for the patient to settle out, particularly if one of the reasons they're going on is for an acid-base disturbance. You're not going to get very good results while they're stabilizing out their acid-base status, but there's not a contraindication for conducting indirect calorimetry while they're on CRT.
So can you repeat that last sentence one more
There's
time?
not a contraindication for conducting indirect calorimetry on CRT.
So you can do it.
Yes.
Can do IC even on CRT.
Absolutely. And I actually find it to be very beneficial, because even with the heaters in line, which I don't know if anybody else has seen this, but like sometimes our heaters go crazy. But even with the heaters in line, patients are losing heat with the blood exchange. So what we see is that any extracorporeal support tends to lower energy expenditure as well. And so we find it very valuable when patients go on CRT to double check their energy needs, because what we tend to find is that their energy needs drop a little bit.
Yeah. Speaking of energy needs dropping, now the case progresses, and unfortunately this poor gentleman is getting worse. And we
really put him through it, didn't we?
So now we are paralyzed and prone. So Ranna, let's say you don't have an indirect calorimetry, right? And so you have whatever calories and protein you're giving it, and then you come into work the next day and find the patient face down with cisatracurium running. What are you going to do that day?
Well, okay, so the first thing I'm thinking, I obviously sedation practices vary from ICU to ICU. If a patient requires a deeper levels of sedation for prone positioning, and I'm always thinking about the barriers to adequate EN. So if they have like really around the clock high dosing of hydromorphone, midazolam, dexmedetomidine, I'm always thinking of a risk of a opioid-induced ileus, delayed gastric emptying. So for me, I want to be proactive to provide some sort of aggressive bowel regimen because these patients can easily go 5, 6, 7 days without a bowel movement. That's going to impact my ability to provide adequate nutrition, and also being ready to add on prokinetic agents if needed. And I probably aim for some post-pyloric feeds. Sometimes we also do a combined post-pyloric feeding with gastric decompression, set to low intermittent wall suction, and using that output as a lever to assess for tolerance. So I'm always just thinking barriers to feeding the patient and what can I do to be proactive to address that? Because I'm like, great, we have these calorie and protein targets, but how are we even going to get there?
Right.
So
very hard to get post-pyloric in a prone patient. Let's just say patient has a nasogastric tube already in place, had a bowel movement like 3-4 days ago, but no, the case has progressed and now the patient is paralyzed and prone. Would you increase, decrease, or keep your calorie and protein targets?
I would probably end up decreasing it a little bit just to account for that lower metabolic needs at that time, the paralysis, yeah.
All right. And what have you seen in indirect calorimetry in your patient population? Is there a pattern? Is there something that we should sort of expect?
Yeah, I will say in my trauma population and in my VV ECMO population, when they're in prone position, I can't conduct indirect because we put our patients completely flat. And when they're in that dependent position, it's impossible to keep the filter dry. But in our MICU population, when they prone, they put them in reverse T. And we've been able to do indirect in those patients, and their needs are typically quite low. And often when your respiratory status is decompensating to the point that you're going into prone positioning, your gas exchange is starting to decline as well. And you're going into prone to try and keep the lungs open, to try and keep things going. And if you're not exchanging your oxygen and your carbon dioxide well, then your drivers of metabolism are going to start to struggle as well. And my concern, I always worry about the mitochondria. So I worry about ischemic mitochondrial damage when you're trying to feed to these high calorie goals, when your patients aren't able to oxygenate well. So I also would probably at that point, not be trying to feed to the same calorie goals that I was when the patient was doing a little bit better. Especially at our center, we're a large ECMO center, so this patient would also be on ECMO watch. And then the other consideration, I had a consideration that went out of my head. As soon as I remember it, I'll share.
Yeah. So both calories and protein. You would decrease. With
protein, the other consideration I remember, we use a lot of propofol, and so with our center, a lot of times with our lower calorie targets and using propofol as our primary sedating agent, our enteral infusion targets tend to be quite low. So the nasogastric access is our only access. Sometimes it's not a barrier because our infusion rates might only be 30 mLs an hour, but I would still try and keep my protein at least somewhat proportional. And I think
20 to 25%?
Yeah, it's something that I double check. And then, I do a lot of math, right? How many dietitians in the room do 7 different calculations and then kind of stand back and look at it and decide which one they like the best?
Yeah. All right, so speaking of ECMO, and I want to progress this case, we have about 3 minutes left, and I do want to include time for questions. So now the patient has really deteriorated and is now cannulated. So I'll start with Ranna. So VV ECMO, the patient is now on VV ECMO. Assuming you don't have indirect calorimetry, how would you then change your prescription?
You see most of the RCTs for ECMO and estimated calorie needs is always that static 25 to 30 kcals per kg. I tend to start around there. Again, I'm always thinking of the barriers to adequate nutrition in my personal practice when patients have a significant clinical deterioration where they need to be resuscitated and stabilized and maybe transferred to another ICU for ECMO cannulation. That comes with another 3 to 5 days in inadequate nutrition sometimes. So they get hit again. So I just want to say for this patient, I actually have a low threshold to restart PN if needed, if I'm anticipating barriers with the transition to ECMO. But yeah, I would aim for maybe about 25 to 30 kcals because I don't have IC in that situation.
So I once was told by a surgeon when I was on ICU service and I wanted to start TPN on an ECMO patient, they were concerned about the lipids clogging the oxygenator. Is that a thing?
We no longer see that as a concern. With our advanced, our modern ECMO circuits, that's no longer a concern. With the new materials they utilize, we no longer see that.
So it's okay, it's safe, and as far as you're aware, it doesn't predispose to chatter or clogging or anything?
It's the hyperlipidemia that's more of a concern. Triglycerides over 1,000 are more likely to cause damage to the oxygenated circuit.
And we would never give TPN to someone with triglycerides of
no, so it's more your,
anyway.
The propofol is more likely to cause that versus the PN.
Okay, and so Stacy, so at Shock Trauma, you guys have indirect calorimetry, and so now what do you do with your ECMO? Can you do IC in ECMO patients?
So we have a novel method to conduct indirect calorimetry in our ECMO patients, and using our method, we've seen their energy needs can range anywhere from 6 to 40 kcals per kilo. Their average needs tend to be lower, more in like the 20 kcals per kilo, 16 to 20 kcals. So I know that we like to extrapolate from general critical illness into ECMO patients, but I think that they really are a unique subset, and that 25 to 30 kcals per kilo results in clinical overfeeding that extends the duration of ECMO. So we tend to feed lower calories and higher protein in that population. Nitrogen balance studies have shown that these patients have a higher degree of catabolism than their counterparts not on ECMO. So we would shift towards lower calories. Even if we weren't able to conduct an indirect on them, we would shift towards lower calories and higher protein at this point.